This is section 3 of the HPT ultrasound training module for surgeons. The focus of this section will be on scanning objectives and patient and equipment preparation and selection. The following are our scanning objectives during ultrasound of the hepatobiliary system. First, the gallbladder has to be imaged completely, taking note of echogenic structures within, also measuring the wall thickness. Second, the extrahepatic biliary tract should be visualized, screened for any obstruction lesion, and the CBD should then be measured accurately. Third, the liver must be visualized well also, taking note of any intrahepatic ductal dilatation or mass lesions. The overall liver echogenicity should also be taken note of. Transabdominal ultrasound of the hepatobiliary system is best accomplished using a low frequency transducer, 5 to 2.5 megahertz, due to the depth of the structures in question. Preferably with a curved array, as they provide adequate tissue penetration while maintaining a broad-based view. Gain and time gain compensation and initial depth setting could then be optimized depending on the structure of interest. Fasting is very important to image the gallbladder properly. 6 hours fasting prior to gallbladder ultrasound is ideal, as this ensures that the gallbladder will be distended as much as possible and there will be minimal intestinal gas. A distended gallbladder would also permit us to find stones or intraluminal echoes easier, while a contracted gallbladder is sometimes very difficult to evaluate even in the best of hands. One thing of note is when you see a contracted gallbladder in a patient with calculus cholecystitis whom you already fasted adequately, this should alert you to the possibility of a complete obstruction of the cystic duct from a stone, as there is no bile inflow to the gallbladder anymore. The supine and the left lateral decubitus position are the two most widely recommended initial scanning positions, patient positions, to image the gallbladder and biliary system. On the supine position, one can try to locate the gallbladder by positioning the probe along the subcostal margin and sweeping the probe medial to lateral. Asking the patient to take a deep breath and holding that position for a few seconds. This maneuver lowers the gallbladder into the peritoneal cavity and might help in gallbladder visualization. One can then turn the patient to a left lateral decubitus position, like the one shown here. No? Here, the bowel loops can be displaced out of the way, and the gallbladder is also moved into the peritoneal cavity better. You will then sweep the probe again along the parasagittal plane across the costal margin to see the gallbladder. Moving the patient into a different position would also permit one to see if intraluminal echoes within the gallbladder are attached to the walls or not. Another commonly used approach is the lateral intercostal approach, which may be done in the supine or left lateral decubitus position. This involves scanning in between the ribs as the probe is placed along different intercostal spaces and the probe is fanned. No. This may be difficult for beginners as the ribs can cause issues in imaging. No. But personally, this is my go-to imaging approach for imaging the gallbladder when presented with difficult to image patients, especially when the gallbladder is located higher up. This slide summarizes the commonly used patient positioning and scanning approaches for HBT ultrasound. We have the transabdominal approach supine, transabdominal left lateral, the lateral intercostal supine, and the lateral intercostal left lateral decubitus position. This ends my lecture on basic scanning objectives and patient preparation and positioning. I will be referencing these in the future lectures, and the scanning techniques specific for gallbladder and the biliary tract will follow next. Thank you for your attention.